We left off discussing healthcare values and the question of what values should we emphasize when designing a health system. We went over in previous videos what might underlie Americans' approach to social welfare, and we said that there were certain values that Americans, by and large, seem to hold: a preference for individualism, this idea that with hard work, we can all pull ourselves up by our bootstraps and attain the American dream. And therefore, poverty was perhaps a symptom of laziness. And we traced it back to Puritan influence. But we also pointed out periods of history that were more progressive, like the social gospel. And we talked about how during that period of time when we had the most progressive social policy, blame was put on society or on the corporations or the persons that were exploiting workers for profit. And the argument went that if you were going to make money off of these people, then you were then responsible for them in some capacity as well, for their welfare, right? You're responsible for their welfare. During this era, we said that individual troubles were seen as a symptom of poverty. Now, individualism is not the only theory, the only value that is focused on in discussions of American policy. There are other values that are equally as prominent. Deborah Stone lists some of these in her work. One of those values is fairness or equity. When people debate policy, you will hear references to what is fair or what is equitable. Another American value that is often referenced in public policy debates is freedom or liberty. Right? This freedom to choose comes up often in healthcare. Americans want the freedom to choose their providers. They want the freedom to choose their health insurance. Americans also value security, as do many others, right? We want to feel safe. You will hear reference to efficiency. Americans want policies that are efficient, that deliver to the outcomes, but do so in the less costly way, right? So here, balancing cost with outcomes is a common discussion in policy. And you will hear welfare as we defined it, right? So when we're talking about welfare here, we're talking about the well-being or the welfare of the people, right? As another value that is discussed in the policy process. So in sum, when debating which types of reforms to enact or how to design a social welfare system, the values that underlie the system, the values that are going to be debated in the polis, in public policy, are going to be values of fairness, freedom, security, efficiency, welfare. Now you might say, well, where does this idea of individualism fall within this menu of values? And individualism really can be put in either fairness or in freedom, right? So the idea that handouts are not fair, that you should get what you work for and that is fair, or alternatively, that we should have the freedom, right? Everybody should have the right to choose their doctors or their healthcare plans. That would fall under freedom. So let's apply these values specifically to healthcare. We want a healthcare system that is fair and that is efficient. Most people can agree on that. But what is fair and what is efficient is agreeing on what is fair and what is efficient is what is difficult. And fairness and efficiency can be at odds with one another. There can be an inherent tension between the two. Let's explore this a little bit further. Most simply, efficiency can be conceived as a bargain. And the ideal or the most efficient policy or program would be one where we have to put in as little as possible into the system as far as resources go, right? We have to put in the least amount of resources and we get out the most desired output. So we spend, for example, the most efficient healthcare system would be one where we put in the least amount of money and get the greatest health outcomes. How do you measure efficiency? Well, that's where it becomes difficult. What is efficient? Well, we defined it as the ratio, putting in the least amount of goods and getting out the greatest output. But we didn't define what those outcomes or that output was going to be. What are the desired outcomes of a healthcare system? Well, those desired outcomes may differ depending on who you ask. So who defines the outcomes may influence what the outcomes are. For example, let's say as part of the design of the healthcare system, providers are encouraged to book patients as close together as possible, to book their appointments as close together. So we have a patient coming in at 12, a patient coming in at 12:15, and let's say that each appointment is only supposed to be 15 minutes long. So the provider books the appointment so there is little to no time in between each appointment. Well, what inevitably happens is that provider, that doctor, for example, is going to run a little bit late usually, right? Because this patient here at 12 might actually take 20 minutes. The doctor might need to go spend 5 minutes, talking to a nurse in between. So they've now shown up at 12:25, and then there's a domino effect, and so this system might be efficient for the provider because the provider doesn't waste any of their time. So they're putting in the least amount of time to get the most patients seen, right? So it's efficient for the provider. For the patient, from the patient's perspective, it's not very efficient for them, right? They have to wait oftentimes hours in the waiting room because the provider is late. they're putting in more time and they're getting rushed out. They might be getting less out of it, right? So efficiency is hard to measure when we're talking about healthcare systems, in part because it's hard to define what outcomes we're looking for, and then it's hard to define the costs, right? Because the costs in this example to the provider are a lot lower, their time, and they're a lot higher for the patient who has to invest more time. So it's important when you're designing your healthcare system and you're thinking about wanting to design an efficient healthcare system, you consider the efficiency to different parties that are involved. Let's talk about fairness. So how do you design a healthcare system that is fair? Maybe it is a healthcare system where medical care is a right? Maybe healthcare should be be able to be accessed by everybody that needs it. Or maybe there's the belief that what is fair is that healthcare should be a good that is bought and sold. Or maybe certain types of healthcare are a right, like emergency care. But maybe elective care should be a market commodity. Or maybe everybody gets access to public hospitals. And if people want to purchase additional frills, they can go to a private hospital, and that would be a market commodity. So a market commodity, if you haven't figured out from context, is a good that is bought and sold in the market. I'm going to hold off on talking about fairness and actuarial fairness and fairness in regards to pre-existing conditions until a little bit later. And then there's this idea or value of solidarity. Solidarity is the idea that we are all in this together. So when we talked about individualism versus a more communal or community-oriented belief system, solidarity is more of a community-oriented system. So it's this idea we're all in it together. Remember social insurance? Well, it really is supported by this idea of solidarity. We're all in it together. We all put in money into the system, and if we need it, we can all access the system when we need it. The solidarity principle you're going to find as we start talking about healthcare systems is more present in the European systems of health. And the idea that society should fund the care for persons that are ill and for those who can't finance it is much more prevalent in communities that strongly believe in the solidarity principle. Now that we've talked about values, I wanted to briefly go back to this idea of deservingness and populations that were deserving or worthy that we discussed in previous videos. And this is a chart by Schneider and Ingram. And they went through and they analyzed how certain groups were socially constructed. And what they found was that groups could be positively or negatively constructed. And constructed means how they are described, how they are talked about in popular discourse. And so if you look in this column here, these groups are considered to be positively construed. And you'll see that the populations that are benefited by Medicare, the elderly here, are very positively construed. Remember that children, mothers, persons with disabilities, these are all groups, veterans, that are provided, you will find, health care in the United States through various types of programs. The Veterans Health Administration, Medicare, Medicaid. Now, those that are construed negatively are often excluded from policy benefits. Teddy says hi, everybody. So these groups could be positively or negatively constructed. But what Schneider and Ingram found was that what also plays into whether or not these groups are benefited from social policies, what also influences or plays into it, is how much political power the groups have. You can see the elderly have strong political power and are positively construed. And so they have the most robust social welfare programs in the United States. Now, children and mothers and persons with disabilities have less protections, but they still are protected, right? They still do have some programs for them. When you get over here, persons that are considered deviants, right? Like persons who have who have been incarcerated. In some states, they don't even have the right to vote, right? They have the least political power and are negatively constructed, and so they're often burdened by policies. Burdened by policies. So I just wanted to point this out because you're going to start to see, as we discuss the nuances of the healthcare system in the U.S., these groups being brought up again and again. All right, so let's move into talking about the U.S. healthcare system.